Hi everyone, our subject today is dysmenorrhea in pediatrics. Basics. Dysmenorrhea is defined as a crampy lower abdominal or low back pain associated with menstruation. Primary dysmenorrhea is absence of any hormonal or pelvic disease. Secondary dysmenorrhea due to hormonal or pelvic disease, most commonly endometriosis. History. Given the high prevalence screen adolescent female for dysmenorrhea, less than 15% will seek medical attention. Pain and its characteristics. Menstrual history, age at menarche, more common in girls with the aerial menarche, more time to progress to ovulatory cycle. Menstrual flow, more common in women with the heavy menstrual flow, menorrhagia. Last menstrual period and previous one if known, length of menstrual flow and total cycle regularity, amount of menstrual flow. Sexual history, parity, current sexual activity, contraception and history of STDs or pelvic inflammatory disease, adhesion may cause painful menses. Associated symptom, missing stool, nausea, vomiting, diarrhea, headache, irritability, fatigue, breast tenderness, dizziness, weakness, or bloating. History of sexual, physical, or emotional abuse. Family history of gynecological disease, including dysmenorrhea, gynecological or breast cancer, and complication with oral contraceptive pills, including DVT, stroke, or myocardial infarction. Medication history, including oral contraceptive, name, dose, when taken in relation to pain, if scheduled or taken as need, perceived effectiveness or not. Diet, higher intake of polyunsaturated fatty acid correlate with the increased menstrual pain. Physical examination, abdominal exam, pre-umbilical pain suggests GIT, not a gynecological source. Enlarged uterus can be palpated in vaginal outlet obstruction, inspection of external genitalia, imperforated hymen, hematocolpus. Pelvic exam, performed in women with history suggesting of secondary dysmenorrhea, a history of sexual intercourse, and those who need a pap smear or who have failed non-steroidal anti-inflammatory drugs. Typically normal in primary dysmenorrhea, may have mild diffuse uterine tenderness. Consider differing in young children with young girls with mild classic symptoms and normal external genitalia who have never been sexually active. How to approach to dysmenorrhea in young girls after performing history and physical examination. If it is a classic symptom of primary dysmenorrhea, normal physical examination, response to therapy. If it is yes, this is primary dysmenorrhea. If it is not respond to treatment or there is atypical symptom, secondary dysmenorrhea. Onset time, characteristic of pain. If it is pain during or immediately after menses, sexually active with or without vaginal discharge, perform pregnancy test. If it is positive, ultrasound, either miscarriage or ectopic pregnancy. If it is negative, cervical culture with or without ultrasound. This is maybe pelvic inflammatory disease or cervicitis. If the pain began with the menarche, pain occur with the onset of bleeding, patient need ultrasound. Could be partial vaginal outflow obstruction, imperforated hymen, rudimentary uterine hole. If the pain, chronic pelvic pain, worse during menses, increase severity of pain, patient need ultrasound. If it is normal, consider referral for laparoscopy if symptom persist more than 6 months. Differential diagnosis, endometriosis, post-infectious scarring, idiopathic or psychogenic. If it is abnormal, differential diagnosis, tumor, ovarian cyst, foreign body, pelvic inflammatory disease. Alert. Pain that start at menarche is not likely primary dysmenorrhea, as most girls are still having an ovulatory cycle. Progressively worsening pain with each subsequent cycle may indicate endometriosis. Cigarette smoking may increase the duration of dysmenorrhea. Consider a workup of endometriosis for hard-to-manage dysmenorrhea. Primary dysmenorrhea has no clinical detected pelvic pathology. It is due to uterine contraction caused by prostaglandin produced by the premenstrual secretory endometrium and occur only with the ovulatory cycle. Less common in the first 2 to 3 years following menarche, more prevalent in mid to late adolescent when cycles are ovulatory. It begins with the onset of menstrual period and lasts from a few hours to days. Cramping may be associated with nausea, vomiting, diarrhea, and headache. The pelvic examination is normal but is usually not clinically indicated. If the clinical presentation is consistent with the primary dysmenorrhea, it is reasonable to do a trial of therapy. Prostaglandin synthetase inhibitors are effective when given before a menstrual period or shortly after it begins. Hormonal contraceptive, oral, vaginal ring contraceptive patch may also be helpful and may be considered particularly for girls who need contraception. Alert! There are a number of oral contraceptive medications that are marketed for treating cramps in women. Only those formulations that contain non-steroidal are effective in treating dysmenorrhea. Encourage patients to read labels looking for medication containing ibuprofen or naproxen. Estrogen and progesterone hormone are also used in treatment of dysmenorrhea and do not lead to adolescent sexual activity. Secondary dysmenorrhea, it is associated with the underlying pathology. It is less common in adolescents and are more common in adults. A new onset of symptoms in sexually active teen may be due to complication of pregnancy or pelvic inflammatory disease. If there is a positive pregnancy test finding, ultrasound evaluation may be needed to exclude an ectopic pregnancy or miscarriage. Rudimentary uterine hurt, onset of symptom with a menarche when cycles are usually anovulatory may be due to Mullerian tract abnormalities with partial outflow obstruction. Pelvic examination, ultrasound, or laparoscopy may be needed to evaluate outlet obstruction. There may be partial obstruction of the menstrual flow, causing cycle dysmenorrhea with accumulation of menstrual fluid, resulting in hematocolpus, hematometra, or hematosalpinx, depending on the level of the obstruction. Endometriosis, chronic pelvic pain that is worse during a period may be due to endometriosis and may be diagnosed using laparoscopy. Endometriosis is the presence of endometrial tissue outside the normal intrauterine cavity. Unlike in adolescent, the pelvic examination may be normal or with maybe minimal tenderness. Psychogenic dysmenorrhea may be related to negative sexual experience such as child abuse or rape. Thank you for your listening.